You know that tiny, seemingly minor chemical that only seems to show up when pollen counts are high, or maybe when you eat something your body just decides it hates?
Mm-hmm.
That little troublemaker is histamine. Most of us sort of file it away mentally as just the thing that makes me sneeze, but if that's your entire understanding of its role, well, you are about to discover you've barely scratched the surface.
Absolutely. It is
Yeah.
truly a master switch for the body.
Hmm.
The name itself, from the Greek histos, which means tissue, tells you everything. It's the tissue amine.
So it's foundational.
It is. The research goes all the way back to the early 20th century. A researcher named Dale, he quickly recognized that the effects of this chemical mirrored precisely what happens during hypersensitivity reactions, the swelling, redness, muscle contraction.
So they pegged it as the allergy molecule right from the start.
They did. It was instantly seen as the primary mediator of allergic reactions and tissue injury. But that initial association kind of hid the fact that it's also a fundamental physiological regulator, constantly active in the brain, the gut, and the heart.
Okay, so our mission today is to give you a true shortcut to being well-informed on this molecule.
Oh.
We're going way beyond the itchy eyes. We're doing a full biochemical and clinical tour.
Right.
We're going to unpack the dual roles of histamine,
Yeah.
identify its three major receptor types, the critical switches it flips, and then trace the fascinating and sometimes scandalous evolution of the drugs we use to block it.
From the old school sedatives that were guaranteed to make you say.
Exactly. All the way to the modern hyper-targeted compounds that really revolutionized allergy treatment, including some of the hard-won lessons in cardiac safety that came with them.
And this is really why you should care. By the end of this, you will understand the precise molecular reason why that old allergy medication made you so drowsy. You'll see how this exact same molecule is the dominant trigger for your stomach acid, and what specific advancement allowed the modern drugs to be incredibly effective and safe, all by avoiding a simple pitfall, the blood-brain barrier.
Okay, let's unpack this hidden switch.
Yeah.
So before we get into what it does, let's talk about the logistics. I mean, what is this molecule fundamentally, and how does the body make it and store it?
Well, chemically, its name is imidazolethylamine. It's a deceptively simple organic compound,
Okay.
and it's synthesized locally, right in the tissues where it's needed, usually in just a single step. An enzyme just clips off a piece of the common amino acid L-histidine.
So it's made from something we all have readily available from food, and it's made quickly, but it's also destroyed quickly, right?
Absolutely. The body has extremely efficient disposal mechanisms. Histamine is rapidly degraded by two main pathways, oxidation and methylation.
So there's a quick turnover?
A very quick turnover. This means histamine isn't something that typically accumulates unless you have a massive release event. And that quick turnover is crucial to understanding why its effects are so tightly regulated, especially in its non-allergic roles.
I'm really curious about the storage. The source material makes this really interesting distinction between two completely different storage systems. It's like having a huge warehouse for emergencies and then a separate, smaller shop for day-to-day use. Let's start with that emergency stockpile. Mast cell histamine.
Right. So mast cells are the major storage depots. They hold the vast majority of all the histamine in your body.
And they're placed strategically.
Oh, yeah, like little security guards. They're in connective tissue, particularly in areas that are exposed to the environment. So the skin, the lungs, the lining of your GI tract, plus the liver and placenta.
What's so fascinating to me is how it's physically held inside these cells. It's not just floating around loose in there. It's locked down.
It is. It's held in these large intracellular granules through a brilliant piece of biochemistry. Histamine is positively charged.
Right, it's an enamine.
Exactly. And inside the granule, it's bound tightly to a complex made of an acidic protein and heparin, which is a highly, highly negatively charged molecule. You can almost picture it like histamine is being held captive inside a negatively charged cage.
Wait, okay, so if it's stored in a negative cage in mast cells, what does that mean for how quickly it can be used? Does that affect its shelf life, so to speak?
It affects its turnover dramatically. Mast cell histamine has a very slow turnover rate. It's built up over time and just stored, waiting, indefinitely for a single acute event. It's a defense mechanism ready to deploy in a massive burst if the body detects a threat. It's the reserved ammunition.
And then you have the other type, the non-mast cell histamine.
Mm-hmm.
This sounds more like the daily operational stock.
Exactly. This type is found in very specific, localized tissues, the brain, the top layer of the skin, and crucially, the gastric mucosa in the stomach.
And the turnover here is fast.
It's very fast, it's constantly being synthesized and then rapidly used up and broken down, which clearly signals its role is continuous physiological regulation. It's a neurotransmitter in the brain, keeping us awake, or a local hormone in the gut telling it to make acid.
Let's get into the trigger mechanism.
Mm.
How does this caged-up histamine actually get out of the mast cell granules and into action during, say, an allergic reaction? You mentioned exocytosis.
Right. So when the mast cell gets triggered, let's say an allergen binds to IgE antibodies on its surface, it undergoes degranulation. The process is called exocytosis.
And what's that?
The entire granule is literally extruded from the cell into the extracellular fluid, but the histamine is still sort of loosely associated with the granule remnants.
And this is where the local physics comes into play.
Yes, this clever chemical exchange. The positively charged histamine is highly soluble, and it rapidly exchanges with the most abundant positive ion out there in the fluid, sodium, Na+O.
So the sodium ions basically knock the histamine free from its cage.
That's a perfect way to put it. This ion exchange allows the histamine to finally be released free and clear into the tissues, where it can now go and bind to cell receptors and kick off that allergic or inflammatory response.
This whole release mechanism is fascinating because it gives us a key control point for drugs, right? We can actively inhibit this process.
We can. A very crucial mechanism involves regulating an internal signaling molecule, cyclic AMP or AMP. Drugs that increase the concentration of intracellular CAMP, like adrenergic agonists, they actually inhibit the exocytosis of these granules.
So you can stabilize the mast cell.
You stabilize the mast cell membrane and basically keep the cage closed.
Right.
It's a primary strategy for preventing hypersensitivity reactions at the source.
I'm still hung up on the logistical point about taking histamine orally. If it's so fundamental, why can't we just pop a histamine pill? The sources are clear that it's orally inactive.
That goes right back to the liver's incredible efficiency. Any histamine that you might swallow gets absorbed from the intestines, but it's subject to the first pass effect. It's immediately and completely degraded by liver enzymes. It just never reaches your systemic circulation in a high enough concentration to have any effect. This just re-emphasizes that histamine is meant to be a local mediator.
So every time we have an allergic reaction, it's like a controlled, localized fire right at the site of exposure.
Exactly, whether it's your nasal mucosa or your skin.
That dual nature is really the key takeaway from this first section. It's made easily, but its function is determined entirely by where it's stored. Slowly in the mast cell security depots for defense, or continuously in non-mast cells for, day-to-day regulation. Now we get to the actual switches that histamine flips. Histamine is the key, but its effect is determined entirely by which lock it fits into. The classification started back in 1966 with Ash and Child, right? They defined the receptors blocked by the allergy drugs at the time as H1.
That was the foundational first step. But the real breakthrough came later. See, they knew that other effects of histamine, like stomach acid production, they weren't blocked by those H1 drugs.
So there had to be another receptor.
There had to be. And that H2 classification was finally confirmed by Sir James Black, a monumental figure in pharmacology, in 1972 when he successfully synthesized a compound called burimamide. It was the first drug that selectively blocked those other actions.
And that work was a complete revolution in GI medicine.
A total revolution.
We know there are 4 receptors defined, but we're focusing on the main 3 from the sources, H1, H2, and H3, with H1 and H2 being the clinically relevant ones for now. Let's start with H1, the classic allergy and contraction receptor.
Okay, so H1 is the high-affinity receptor for histamine. It's the one we're trying to block when we treat allergies. The conventional antihistamines like meperamine or chlorpheniramine are highly selective for it.
How selective are we talking?
The sources note chlorpheniramine has a 15,000 to 1 selectivity ratio for H1 over H2. That's incredible precision, especially for an older drug.
Let's talk about the cellular mechanism, because this dictates all the symptoms we associate with an allergy. How does binding to H1 actually cause a physical contraction or fluid leakage?
The H1 receptor is coupled to a signaling protein called the GQ protein.
Yeah.
Think of the H1 receptor as the trigger, and the GQ protein as the immediate circuit breaker. When that trigger is pulled, the GQ protein kicks off a cascade that yields 2 messenger molecules, IP3 and DAGO.
What is the immediate non-negotiable consequence of that cascade?
The crucial step is the dramatic release of calcium ions Ca2 plus I from storage compartments inside the cell.
Calcium.
Calcium influx is the body's universal signal for action. In smooth muscle cells, high internal calcium causes contraction. In the cells lining your blood vessels, it causes them to pull apart slightly.
That perfectly explains the key actions we see. First, smooth muscle contraction.
Right. This is why you can get intestinal cramps or, more dangerously, bronchoconstriction in the lungs, the tightening of the airways. In sensitive people, especially those with asthma, H1 activation can quickly trigger airway closure.
Second, the vascular effects, the visible signs of inflammation.
Here, H1 activation acts on the capillary endothelium, the lining of the blood vessels. It signals the release of potent local vasodilators like nitric oxide and prostacyclin.
So the vessels relax and widen?
They do. But critically, that calcium signal also causes the endothelial cells themselves to contract and separate slightly, widening the gaps between them.
This is the floodgate opening we talked about.
It is. It leads to a massive increase in capillary permeability and the leakage of fluid into the surrounding tissue. That leakage is what causes the wheal, the swelling, the puffiness.
And finally, the sheer annoyance. The itching and the pain.
That is a direct result of H1 activation on afferent nerve endings. Histamine is widely considered the transmitter responsible for sending that initial sensation of itch and sharp pain from the periphery up to the brain.
Let's pivot to H2. This receptor's classification, thanks to Sir James Black, fundamentally changed how we treat things like heartburn and ulcers.
It really did. The H2 receptor is defined by its selective antagonists, like cimetidine and ranitidine, which were blockbuster drugs for decades. And H2 operates on a totally different signaling pathway, which gives it entirely different functions.
So how does this mechanism differ from the immediate calcium dumping action of H1?
H2 receptors are coupled to the stimulatory GS protein. So think of this not as a circuit breaker, but as a slow, steady signal amplifier.
Okay.
Activation turns on an enzyme, adenine cyclase, which dramatically increases the concentration of cyclic AMP, or CAMP, inside the cell. Increased AMP then kicks off a whole other chain of events.
So if H1 is about rapid physical contraction via calcium, H2 is more about chemical amplification via CAM-MP. Where is this amplification most dominant?
Unquestionably, in the gastric glands of the stomach, activation of H2 receptors on the parietal cells is the single most dominant physiological mechanism for mediating the secretion of massive amounts of hydrochloric acid.
Which allows us to digest food.
Exactly.
But it's not just the stomach, is it? What other organs listen to this GS protein signal?
The cardiovascular system listens very closely. H2 activation causes smooth muscle dilation, which contributes to vasodilation systemically, but in a slower, more sustained way than H1. And more dramatically, in the heart, H2 receptors are found in the atria and ventricles. Activation there causes positive chronotropy, so an increased heart rate, and positive inotropy, which is an increased force of contraction. These are significant direct cardiac effects.
Finally, H3. This receptor is fascinating because it acts like a self-regulating thermostat or a brake pedal, almost entirely within the nervous system.
That is the perfect analogy. H3 receptors are primarily found presynaptically right on the nerve terminal that is about to release histamine.
So it's a feedback loop.
It's a feedback loop. Its primary function is autoregulation. It controls, or rather inhibits, the release of histamine from those neurons. When the cell releases too much histamine, that histamine binds to its own H3 receptor, telling it to shut down.
And its mechanism is basically the opposite of H2.
It's the inhibitory equivalent. H3 is coupled to the GIGO protein. Activation leads to a decrease in the stimulatory CAMP and a bunch of other things that basically suppress the neuron and inhibit neurotransmitter release.
So when H3 is activated in the brain, it inhibits the release of histamine, which we know is the wakefulness transmitter. This must be a huge target for future neurological drugs.
Absolutely. Presynaptic inhibition of histamine release means reduced alertness, which translates directly to sedation.
So an H3 blocker would do the opposite.
An H3 antagonist, a blocker, would increase central histamine release, promoting wakefulness and cognitive function. And this is exactly why this receptor is a huge area of pharmaceutical development for conditions like ADHD or narcolepsy. H3 receptors also help regulate the release of other transmitters, like acetylcholine in the gut, adding another layer of complexity.
But despite the development of selective compounds like teprolisant, we have to reiterate the source's note that H3 antagonists have not yet crossed the finish line into broad clinical use. The potential, though, is enormous. We have the molecular map, H1 for contraction and permeability, H2 for acid and heart rate, and H3 is the neuronal brake. Now let's zoom out and see what happens when the body is just flooded with histamine and all these receptors get hit at once.
The clinical gold standard for observing histamine's vascular effects is the triple response. It's what you see when a tiny amount of histamine is injected just under the skin. It's a rapid, visible physiological show.
Okay, part one, the red spot.
This is immediate, within seconds, right at the injection site. It's purely due to intense local capillary dilation. Histamine hits the H1 receptors on the vessels, and they immediately widen and fill with blood.
Part two, the wheal. This is the swelling, the leakage we talked about before.
The wheal follows the red spot. It's that pale, raised area. And this is the fluid leakage, the exudation of plasma from the capillaries, driven by that increased permeability from the H1 calcium signal. It's a temporary controlled leakage of the local blood vessels.
And the third part, the flare, which spreads out into the surrounding area, making the skin red far beyond where you actually injected it.
The flare is a beautiful example of reflex biology. It's caused by an axon reflex.
What's that?
The histamine stimulates local sensory nerve endings. They send a signal back towards the spinal cord, but instead of reaching the spine, it reverses direction at a nerve branch and travels back down to the surrounding arterioles, causing them to dilate. This spreading redness is the body signaling irritation in the entire vicinity.
It's interesting how the vasodilation effects, which can lead to a fall in blood pressure, are split between the two major receptors.
That's a critical distinction. The fall in blood pressure is bipartite. There's an early, sharp, but short-lasting component that's mediated by H1 activation. This is an indirect effect, driven by the H1-induced release of nitric oxide from the vessel lining. The second component, which is slower but more persistent, is the H2 response, which is a direct relaxation of the vascular smooth muscle.
So if someone is in shock from a massive histamine release, you need to hit both switches.
Exactly. But remember the affinity difference. H1 receptors have a higher affinity. Low doses of histamine only hit H1, causing that quick NO-mediated drop. Only when you have a massive amount, like in a systemic reaction, do you recruit the H2 effects and get that slower, more dangerous, persistent drop in blood pressure.
So if the triple response shows the vascular effects, the gut shows the dominant physiological role of H2. The sources are very clear. Histamine has a dominant role in mediating hydrochloric acid secretion.
This is where that fast turnover non-mast cell histamine is critical. These specialized histaminocytes sit right next to the parietal cells in the stomach lining. Under normal stimuli like the smell of food, eating, or the presence of gastrin, this local histamine is rapidly released.
And the mechanism is H2 activation, increasing KMP, which turns on the pump.
Precisely. The increased KMP activates the final common pathway, the proton pump, or H plus K plus AT pace. That pump is the machine that physically shoves acid into the stomach.
Here's where the complexity really shines, though. The synergy. The sources mention histamine, acetylcholine, and gastrin mutually amplify each other. What does that mean in practical terms?
This synergy is why histamine is the linchpin. Imagine baking a cake where you need flour, eggs, and sugar. Acetylcholine and gastrin are the eggs and sugar. They stimulate acid secretion, but their response is relatively weak on their own. Histamine is the flour.
Oh.
When all three are present, they mutually potentiate each other. Histamine makes the parietal cell exponentially more sensitive to the effects of the other two.
So blocking histamine is like ruining the entire recipe.
That's it exactly, because histamine plays that dominant synergistic role. When you use an H2 blocker, you don't just suppress the acid caused by histamine itself, you markedly diminish the response to the other two major secretagogues. It's just a phenomenally efficient pharmacological target.
Let's go back to the acute allergic response, the domain of the mast cell. We know that histamine release after an antigen-antibody reaction causes things like hives and bronchoconstriction.
Right. And H1 antagonists are excellent for controlling those visible symptoms of immediate allergy, the urticaria, the itching, the localized swelling. But we have to make this distinction crystal clear for everyone listening. When we talk about severe, life-threatening reactions, the story changes dramatically.
The crucial detail here is the failure of H1 antagonist in human asthma and anaphylactic shock.
Absolutely vital. In humans, especially in conditions like anaphylaxis or severe asthma, other mediators take the stage and become dominant. These include the leukotrienes, especially LTD4, and platelet activating factor, or PAF.
And those are more powerful.
They are far more potent bronchoconstrictors and vasodilators than histamine in these severe systemic reactions.
So this means relying on an antihistamine during anaphylaxis is a dangerous mistake.
It is life-threatening malpractice. H1 antagonists are too slow, and they are ineffective against the dominant mediators in that scenario. If a patient is suffering anaphylactic shock, the only life-saving intervention is adrenaline. epinephrine.
Hmm.
Antihistamines are strictly secondary or adjuvant therapy. You use them only to help reduce the rash and itching after the immediate threat to the airway and circulation has been dealt with by adrenaline.
Moving to general inflammation, histamine also has a clear role there, right?
Mm.
Promoting the defensive posture.
It contributes to all phases of acute inflammation. A specific function is facilitating the immune response. Histamine promotes the adhesion of white blood cells to the vessel lining by inducing the expression of adhesion molecules like P-selectin. This basically traps the immune cells where they're needed to fight an infection or injury.
And circling back to the nervous system, its role as the afferent transmitter for itch and pain.
Yes, it's the localized sensory nerves reporting damage or irritation. Histamine release is one of the quickest ways to trigger those nerve endings, alerting the brain that something is wrong.
Now, the CNS role. We noted earlier that if you inject histamine into the bloodstream, you don't see any central effects. Why does the blood-brain barrier hold up so well against this fundamental molecule?
But the BBB is a highly selective gatekeeper. It's designed to protect the fragile environment of the brain, and histamine, being a relatively polar molecule, can't easily diffuse across that lipid barrier.
But the brain isn't histamine-free.
Not at all. Non-mast cell histamine is synthesized locally, in situ, primarily by neurons that originate in the hypothalamus and then project throughout the entire brain.
And this centrally located histamine has one very specific critical job that explains the sedation we see with the older drugs.
Its primary function is maintaining wakefulness and arousal. Central histamine neurons fire rapidly during waking hours, and they virtually cease firing during sleep. It is a fundamental alerting neurotransmitter.
So if a drug can get through the blood-brain barrier and block those central H1 receptors,
You're artificially shutting down the system that promotes alertness. The result is sedation, lightheadedness, and fatigue.
that shift in perspective is wild. I always thought the older antihistamines were actively making me sleepy, but they were actually just blocking a function critical to staying awake.
That is the essence of pharmacology. They don't add new functions, they block existing ones. And beyond wakefulness, central histamine is involved in other crucial regulatory roles, governing body temperature, modulating cardiovascular function, and regulating thirst. And as we mentioned, H1 agonism also actively suppresses appetite, which is a therapeutic target for weight management research.
Okay, now we can transition into the historical development of the drugs themselves. The first generation of H1 antagonists came out in the late 1930s. They were effective, but they all came with that famous or infamous trade-off.
These drugs act as competitive antagonists. They compete with histamine for the H1 receptor binding site, effectively blocking its access. The problem with this first cohort is that their chemical structure lacked sufficient selectivity and was very lipophilic.
Meaning they could hit other receptors and cross the blood-brain barrier easily.
With ease. They were effective at blocking histamine's effects, the triple response, the bronchoconstriction, the itch, but their pharmacological actions went far, far beyond just H1 blockade.
The most problematic off-target action being their anticholinergic activity.
Yes. Many first-generation H1 blockers also antagonize the muscarinic actions of acetylcholine or ASHI, and acetylcholine controls everything from your salivary glands to your bladder function.
And this explains the classic drying side effects we see with drugs like, say, diphenhydramine.
Exactly. Blocking HH leads directly to the dry mouth, blurred vision, and urinary hesitancy that are so common with these drugs. This property is very high in compounds like promethazine and diphenhydramine. On the other hand, a drug like chlorpheniramine has relatively low anticholinergic activity, which often makes it feel less burdensome for patients.
Let's focus on the CNS effects again, because that's the defining characteristic.
Yeah.
The first-generation drugs are CNS depressants.
Yes. Because they're lipophilic fat soluble, they penetrate the blood-brain barrier readily. They block those central H1 receptors, leading to that profound dose-dependent CNS depression. Sedation, lightheadedness, impaired psychomotor skills, motor incoordination.
And the degree of sedation is actually highly varied, even among this old cohort.
It is. It's a spectrum that really dictates their common uses. Diphenhydramine, which is Benadryl, and promethazine are highly sedative. They're often used intentionally for sleep or acute agitation because of this property. Then you have moderately sedative drugs like cyproheptadine and mildly sedative drugs like chlorpheniramine, which is often preferred for daytime use within that first generation, although you still need to be cautious.
Were there any beneficial uses derived from these off-target effects?
Yes. Quite a few. Their anticholinergic properties were harnessed to treat motion sickness and vertigo. The high anticholinergic and sedative properties of drugs like diphenhydramine also gave them an auxiliary use against Parkinsonism, helping to reduce tremor. And then there's the appetite stimulation of cyproheptadine, which is a triple threat. It's an H1 antagonist, it has anticholinergic action, and it even blocks 5-HT2 serotonin receptors.
It is wild that a single molecule designed to stop you from sneezing ends up making you hungry, dry, sleepy, and good at ignoring bumps on the road.
The lack of specificity in these older molecules created a motley of drugs, as the source calls it, each with a wide and often unpredictable array of actions.
Let's clearly define the conventional drawbacks arising from this lack of specificity. Sedation is number one.
Sedation is the single most common complaint, and it's a major safety concern. It impairs cognitive function and psychomotor performance, meaning patients are advised against driving or operating complex machinery. And critically, alcohol and other CNS depressants synergize with this effect, sometimes leading to dangerous levels of impairment.
And the anticholinergic drawbacks are equally annoying, if not always as dangerous.
Dry mouth, difficulty passing urine, altered bowel motility, blurred near vision. While usually just uncomfortable, these effects can be dangerous in elderly patients, potentially causing confusion or exacerbating conditions like glaucoma.
What happens in an acute overdose? Does the sedation just get worse until a person falls asleep permanently?
Ironically, no. Overdose causes a phase shift. The CNS depression is replaced by central excitation. You see tremors, hyperactivity, hallucinations, muscular incoordination, and eventually convulsions. This profile, especially when combined with the severe anticholinergic block, creates symptoms resembling acute belladonna poisoning. Flushed skin, high fever, delirium. Death is typically due to overwhelming respiratory or cardiovascular failure.
That is a severe toxicological profile. Finally, the pharmacokinetics of the first generation really confirm the root of the issue.
They're generally well absorbed and metabolized in the liver, but the key is their distribution. They are highly lipophilic, they distribute widely across the body, and critically, they cross that blood-brain barrier, which guarantees their central effects. Their short duration of action, typically 4 to 6 hours, also means you have to take multiple doses, which keeps the patient in a cycle of CNS impairment.
The stage was set for a revolution. We needed the efficacy of H1 blockade without the sleepy, dry, systemic side effects. After 1980, we got the second-generation antihistaminics, or SGAs, and the change was profound.
This generation represents a huge leap in pharmaceutical chemistry. It focused on two primary goals: enhancing H1 selectivity and, crucially, eliminating CNS penetration.
So the SGAs are characterized by the absence of CNS depression.
Absence of CNS depression, minimal or no anticholinergic side effects, and often additional antiallergic properties like modulating the release of leukotrienes and PAF.
And they achieve the absence of CNS depression simply by changing the molecule's ability to cross the BBB.
Exactly. They are generally larger, more polar molecules, or they're actively pumped out of the brain by efflux transporters like P-glycoprotein, even if they briefly sneak in. So they're highly effective at blocking the peripheral H1 receptors, causing allergy symptoms, but they are functionally locked out of the brain.
So no central blockade, no sleepiness, no driving impairment.
And no potentiation of alcohol.
The second generation wasn't without its massive high-profile stumbles, though. The scandal involving terfenadine and estemazole taught the entire pharmaceutical industry a brutal lesson about cardiac safety.
This is a critical historical anecdote. Terfenadine and estemazole were hugely successful at first because they were the first truly non-sedating allergy drugs. However, clinicians started noticing cases of severe and often fatal cardiac arrhythmias in patients who took high doses or, and this is the key, who were co-administered drugs that inhibited the CYP3A4 liver enzyme.
What was the underlying mechanism of this toxicity? Why did blocking a histamine receptor cause heart failure?
The parent drugs themselves, or their metabolites, were discovered to block the delayed rectifier potassium channels, K+ channels, in the heart muscle.
Okay.
These channels are essential for the heart cell to repolarize, to reset electrically after a heartbeat. When you block these channels, you prolong the electrical recovery time, which is measured as the QTC interval on an ECG.
And this prolonged QTC interval creates the perfect condition for torsades de pointe,
which is a life-threatening, chaotic ventricular tachycardia. When patients took CYP3A4 inhibitors, like common antibiotics or antifungals, their livers couldn't break down terfenadine or estemazole. This led to dangerously high concentrations of the drug, triggering this fatal channel blockade. Both drugs were eventually withdrawn from the market.
This brings us to fexofenadine. It's a pharmaceutical success story born directly out of that failure.
It is. Fexofenadine is the active metabolite of perfenadine. This is genius drug design born out of necessity. Since fexofenadine is already the active drug, it undergoes minimal further metabolism by that CYP3A4 pathway.
So it bypasses the problem.
It completely sidesteps the problem. It also has a low affinity for those delayed rectifier K+ channels, dramatically reducing its arrhythmogenic potential. This simple metabolic refinement essentially fixed the catastrophic drug interactions that killed its parent compound.
So it's safe to say fexofenadine is largely free from that arrhythmogenic risk.
Yes, it is largely free of that risk. It's minimally metabolized, avoiding those complex drug interactions. However, even fexofenadine should be used with caution in patients who already have pre-existing risk factors, like congenital long QT syndrome or electrolyte imbalances. The overall safety margin is high, but the cardiac lesson remains paramount.
Let's quickly review the major players in the second generation, starting again with fexofenadine.
Fexofenadine is highly desirable due to its long half-life, 11 to 16 hours, so it provides 24-hour efficacy with minimal CNS effects. And as we noted, its excretion, largely unchanged, is a major safety feature.
Then there is loratadine.
Loratadine is another excellent non-sedating option. It is quickly metabolized by CYP3A4 into an active metabolite, desloratadine. But unlike tofenadine, loratadine and desloratadine don't seem to accumulate to levels that cause significant cardiac issues, even in overdose. Desloratadine itself is often used as a standalone drug, being the major active component with an even longer half-life of 17 hours.
Next, cetirizine. This one is unique because it sometimes causes mild sedation, unlike the others. Why the slight deviation?
Cetirizine is the active metabolite of the older, highly sedative drug hydroxyzine. While it has a marked affinity for peripheral H1 receptors and penetrates the brain poorly, it does occasionally cross the BBB or interact with the brain's transport systems in a minority of users, which results in those reports of mild subjective sedation.
But cetirizine also comes with an important secondary benefit regarding inflammation, right?
Yeah. It does. It has superior efficacy in certain skin conditions, urticaria and atopic dermatitis, because it inhibits the release of other mediators like eosinophil chemotaxis during the secondary inflammatory phase. It accumulates well in the skin, giving it a powerful anti-inflammatory edge.
And it's active enantiomer, levocetirizine.
Levocetirizine is the refinement of cetirizine. It's effective at half the dose and is reported to be generally less sedative. It's used widely for upper respiratory allergies and as an adjuvant therapy in seasonal asthma.
Finally, let's look at azelastine and evastine.
Azelastine is notable for its excellent topical activity, primarily used as a nasal spray. It's a true multifunctional drug, blocking H1, inhibiting histamine release, and fighting inflammation from leukotrienes and PAF.
The drawback.
Its metabolism is inhibited by CYP3A4, so caution is required, and it can cause local side effects like stinging and altered taste. Evastine, on the other hand, is generally non-sedating, but due to animal studies linking it to QTc prolongation, it carries a potential, though low arrhythmogenic risk.
And a quick mention of rupatadine.
Rupatadine is one of the newest SGAs. It's specifically distinguished by having an additional platelet activating factor antagonistic property alongside its H1 block. This makes it particularly effective for allergic rhinitis, where PAF might be a significant co-mediator.
We've seen the evolution of the drugs. Let's finish by reviewing the clinical reality. Where do H1 antagonists shine, and crucially, where are they inadequate?
H1 antagonists are palliative. They treat the symptoms of histamine release, not the root immunological cause. They are highly effective in controlling immediate type allergies where histamine is the primary peripheral mediator.
So we're talking about relieving acute, visible misery.
Exactly. They are the first-line treatment for itching, controlling hives, seasonal hay fever, the sneezing, the runny nose, the itchy eyes, allergic conjunctivitis, and localized swelling of the lips or eyelids. They provide reliable relief in those scenarios.
But the limitations are so essential to remember, especially for severe reactions.
This cannot be overstated. They are largely ineffective in treating severe bronchial asthma, and they are never the primary treatment for anaphylactic shock. As we established, in human asthma, leukotrienes and PAF are the crucial constrictors.
And an anaphylaxis.
The massive systemic vasodilation requires the intense vasoconstriction and bronchodilation that only adrenaline can provide. If you suspect anaphylaxis, adrenaline is life-saving. The antihistamine is merely an adjuvant to make the patient less itchy afterwards.
What about chronic cases, like chronic urticaria, that don't respond fully to a single SGA?
In those complex cases, some clinicians find success by combining the H1 antagonist with an H2 antagonist. This suggests that H2 receptors also play a subtle, though less dominant role in those chronic vascular responses, and blocking both receptors provides a more complete anti-inflammatory effect.
The unwanted side effects of the first generation actually created new, intentional clinical uses, particularly in motion sickness.
That's correct. Promethazine, diphenhydramine, and dimenahydrinate are invaluable for motion sickness prophylaxis. Their strong anticholinergic property is crucial here, as they suppress vestibular input, the balance signals, from the inner ear.
But the timing is critical.
They must be taken about an hour before travel to saturate the receptors.
And for vertigo specifically.
For general vertigo, the H1 antihistaminics with strong anticholinergic action are used as labyrinthine suppressants, quieting the hyperactive inner ear. Cinnarizine is a prime example. Its anti-vertigo action likely involves modulating calcium fluxes in the vestibular nuclei, essentially calming the overfiring nerves that cause the spinning sensation.
The specific application for Meniere's disease involves a molecule we haven't discussed, beta-histine.
Beta-histine is unique. It's a histamine analog. It's described as a weak H1 agonist and a potent H3 antagonist.
That blocks the brake pedal.
It blocks the H3 autoreceptor, potentially increasing local histamine levels. This is hypothesized to cause vasodilation in the internal ear, thereby reducing the pressure and symptoms of Meniere's disease. It's a very targeted, local approach.
Finally, the common cold. Why are the old sedating drugs preferred for symptomatic cold relief over the new non-sedating ones?
It goes right back to the side effects. The old drugs provide relief not because they fight a histamine-driven cold, a cold is viral, but because their anticholinergic action reduces the runny nose by drying up secretions.
And the sedation helps you rest.
The sedation makes the patient feel better and promotes rest. Since the new SGAs lack this beneficial anticholinergic drying effect, they are often less effective or simply irrelevant for cold symptoms.
We should give a brief nod to the other antagonists. H2 antagonists are a massive field in their own right, primarily in GI medicine.
The path from Sir James Black to cimetidine and ranitidine was a medical triumph. Their primary clinical use is strictly to reduce gastric acid secretion treating peptic ulcers, GERD, and hypersecretory states. They are functionally disconnected from the allergic sphere except as that adjuvant in chronic urticaria.
And H3 antagonists, while chemically identified and understood, remain an exciting future target.
Precisely. Compounds like teprolicant are well studied, but they currently lack mainstream clinical utility. However, the potential to modulate central histamine release for conditions like narcolepsy or cognitive enhancement by blocking that H3 autoreceptor makes this perhaps the most promising area for future CNS drug development in this entire field.
That truly brings us to the end of our deep dive. We started with one tiny, misunderstood molecule, histamine, and saw how its three receptors, H1, H2, and H3, act as the body's hidden switches, regulating everything from your ability to stay awake, to the acid content of your gut, to the difference between a mild rash and a life-threatening systemic shock.
The journey from the first to the second generation of antihistamines is a perfect case study in pharmacology. The essential difference isn't about greater potency, it's about refined pharmacokinetics. The ability of the second generation to avoid crossing the blood-brain barrier, a simple physical property, completely eliminated the debilitating CNS depression and anticholinergic side effects.
Making them effective without compromising the patient's quality of life or safety.
Exactly. A lesson tragically underscored by the cardiac toxicity of the early SGAs.
Thank you for joining us on this deep dive into the world of histamine regulation.
It was my pleasure.
And here is a final provocative thought for you to mull over. Since we learned that H1 agonism in the brain naturally suppresses appetite, and some older H1 antagonists, like cyproheptadine, actively stimulate it, how might pharmaceutical development target central histamine receptors in the future to manage obesity? The challenge is creating a drug that suppresses appetite by, say, activating the H1 receptor in the hypothalamus, or perhaps blocking the H3 autoreceptor to increase natural histamine release, while completely avoiding the massive sedative and anticholinergic effects that plagued the first generation. The key might lie in engineering a molecule that specifically targets the H1 receptors in the hunger centers of the brain, while ignoring those in the wakefulness centers, proving once again that specificity is the final frontier of modern medicine.